With us for this webinar. Today we have a lot prepared for us as our learning session. And I start with an appreciation to Kenyatta National Hospital in collaboration with the University of Nairobi for providing this platform. And today we have two panelists, and we'll be discussing on an issue that is so pertinent and so important in our history and currently in healthcare matters. Our topic today, as projected, is quality improvement tools in Kenya quality model for healthcare. And I am your moderator, Anne Wanyeke, and I'm also the vice chair in Society of Quality Healthcare Kenya. As a way of introduction to our speakers who are joining us today, I will first introduce our first speaker. I just created a preamble of what we're discussing this afternoon. As we all know, that the government of Kenya, through the Ministry of Health, is really committed in ensuring that all citizens in Kenya are achieving the highest quality of healthcare possible. This is well enshrined in the Bills of Rights in the Constitution of Kenya, that was enshrined in 2010, and under the social pillar in the Vision 2030 of this country, there's a long-term development plan, a blueprint, which recognizes the need to improve the overall livelihoods for all Kenyans. And this is the health, this is to provide efficient and high quality healthcare systems with the best standards across the hospital. And I do appreciate the Ministry of Health, the private sector, in all the partnership that is doing to provide this quality care in all sectors in Kenya. And for us to achieve this can only be done through the implementation of the Kenya Quality Healthcare Model or health standards. And this is not only for the Ministry of Health, but also for private sector. Then this becomes a very good platform for us to implement and achieve the best quality and, of course, patient sector in healthcare. So to unpack this after this afternoon, we are joined by Mr. Francis Muma. Mr. Francis Muma is a fellow, is a public health specialist from the University of Nairobi, and also a fellow in the Institute of Tropical and Infectious Disease. Mr. Muma is currently the Kenya Quality Model for Health National Facilitator in the Division of Quality Improvement in the Ministry of Health. So, Mr. Muma, we are all ears, ready to hear from you. You're welcome to unpack these tools. And to all participants, once again, kindly drop your questions under question and answer. At the end of the session, we'll be answering all your questions. Welcome. Mr. Muma, over to you. You can project to us your slides. And also, I would like, as he projects his slides, I would also like to appreciate those who are presenting with us, who are partner to us this afternoon. We have the Ministry of Health. We also do have the Rural and Urban Private Hospital Sector Association of Kenya. And we do have Kenya Association of Private Hospitals. And of course, the Kenya Society for Quality Healthcare, Kenya. And we invite you as a society, and I would like to say that this society is registered by the Registrars of Society of Kenya. And our aim is to support the Kenyan health system to provide and to promote good quality and safe healthcare practice among all communities, healthcare providers, and all health organizations in Kenya. And this society is open for all health workers, all clinicians. Please do register, and we'll, at the end of this session, we'll be sharing to you the details where you can drop in your application and join this group of people who are so passionate to improve quality and patient safety in Kenya. Welcome. Welcome, Dr. Muma. Mr. Muma? I can see he's connected to the audio. Unmute, Muma, and proceed. Use Mr. Peter, who is our second presenter this afternoon. Mr. Peter Mtanda is a healthcare quality improvement specialist with experience in strategic healthcare management. He has postgraduate training in healthcare management from University of Strathmore and also University of Atlanta, where he specialized in health administration and numerous technical and quality management training courses. Peter has been very active in healthcare service delivery and healthcare management for the last 17 years, where he started with managing facilities and healthcare programs, which is not limited to emergency and family health options of Kenya, Maristop, international rescue, and university research. He has also worked with GPEGO and also has worked with International Planned Parenthood Federation. Currently, Peter is a technical coordinator with the International Rescue Committee and a quality initiative faculty of the Institute for Healthcare Improvement, IHI. He is a member of Society for Quality Healthcare and a very active member. So allow me to welcome Peter. Peter, you can put your slides on a presentation mode. And then Karibu Sana, Peter. Yes, please take it on. Thank you.
Thank you. And please confirm you can hear me well.
Yes, we can hear you very well, Peter.
Okay, thank you. I was to be the second presenter, now I'm the first presenter. Okay. Now, so once again, thank you very much for giving me this platform. Thank you for the society. Thank you for the participants who've gotten time to join us in this discussion. So this is, like Anne has mentioned, this is a joint venture between the society and many other stakeholders. And of course, we appreciate the University of Nairobi and the Kenyatta National Hospital Research Department for always allowing us to use this platform to share our ideas, our lessons, our experiences in the QI quality improvement environment. So I was to come after Muma. Muma was to give us the ministry and the government sort of perspective so that we can hitchhike on that, but nevertheless, let's continue. So I'm going just to speak about the essential quality improvement tools. We've been running these webinars for some time now, and our focus has been maybe to sensitize more and more to reach those who may not be in the sort of mainstream government trainings around quality improvement. For those who are interested to know about these modules, we can always speak about maybe further or broader discussions or trainings in due course. So I'm just speaking about the improvement tools. So in the country, maybe Momo was going to speak a lot to this. We have guidelines. I think we've been having guidelines for some time now. We've had a training curriculum which has been in existence for more than 10 years. We've had standards that were developed some time back. I think it's now 5 or 6 years ago. We have a national framework for accreditation and certification, which was launched 2 or 3 years back. We have the core standards that highlight essential key standards in the different health sector. But I also know that many other thematic areas like the HIV, the TB, the MNH, and also the family planning programs have also developed their own quality standards, which are being either rolled out or being implemented in different phases in the country. Under KQMH, for those who attended the March webinar, you may have heard about the KQMH e-platform from Dr. Kandie. And this is a platform that is available for use in the country in terms of assessing the standards of care. And it's quite comprehensive in terms of looking at the key elements that will guide a team to identify gaps or service delivery obstacles, and then come up with improvement ideas on how to fix those gaps. Not limited to the public sector. Of course, the private sector is also awash with a lot of modules, platforms, accreditation platforms. Some of them have been used in this country by many private hospitals, starting with the common ISO standards to the more sophisticated ones like the JCI that is now used by major hospitals in this country. So we have all these guidelines, we have all this guidance, we have all these platforms that looks and checks on the best practice application of the standards, what the patient or the client desires when they come to the healthcare settings. So we can't say as a country that we lack direction. I think the thing that we've been struggling for some time is how do we use the findings that we get from these assessments, checklists, to ensure that the quality of care is up to what is expected. So I'll speak to the quality management, the trilogy that has 3 elements. There's the element of the quality planning. So many times when you speak about quality improvement, and we address the frontline healthcare workers. Many times we rush to talk about quality improvement, the QI element. How are you going to improve your processes at service delivery? But quality has to start from the planning stage. How are you factoring in the planning for your processes, for your activities, So and all these elements have their own tools that are applied at different stages. We have when you're looking at the organization, how does it identify the customer needs? How does it identify what needs to be designed into the processes? What strategies are going to be employed to meet those desired outcomes? We have the quality control, which looks at how do we establish performance standards. We have guidelines, we have standards, we have training curriculums, and we have all these checklists that look at how do you ensure that things are being done to the right standards. Now we have the quality improvement. Now this is now where we have a lot of groundwork. I mean, in terms of deliberately teams going all out to identify gaps in the system, gaps in the processes, and trying to see how can they achieve better performance. So as much as the quality planning and the quality control are so grounded in management principles and the management structures, a lot of the quality improvement issues or structures are more driven based on the need, based on the findings, and they change every time, depending on the situation, depending on the client preferences. You can be using the same guidelines, but people have different quality desires based on the customer preferences and also based on the settings that they work in different parts of the country or the world. So and all these components, the 3 components, have their own tools that are applied in different. So I'll just speak to maybe highlight some of the tools that are used in some of these areas. So in quality planning, and again, just to mention, because you may have seen this, you may have encountered it, you may have done it in your own situations. We have the voice of the client, the customer feedback loops that are done everywhere across the sector. But whenever we do customer feedback sessions, we always feel like the customer is a consumer of the healthcare service. But at the same time, we need to realize that the customer is also a supplier of information. The customer is a supplier of data to us. You get wrong data from the client, you get wrong history from the patient, then that means you're going to use that to provide bad care. So when you look at the client as a consumer, we also need to look at that client as a provider of information that will be very, very useful to effect any service changes or any process changes. We have the quality function deployment. A lot of these have been applied more in the manufacturing sector, but they've gained quite a lot of prominence in the healthcare industry lately because of their uniformity and also the application in patient needs and healthcare services. Benchmarking, I mean, everyone has seen this or heard about this before, so I don't need to elaborate on that one. So the quality planning process, you are looking at the cost benefit analysis, the value for money. What is this that you are trying to initiate or to scale up or to start or to redo or to rework? Does it make sense in terms of the cost versus benefits in the improvement project? We also have tools that we use for design of experiments or design of scale. For example, you want to optimize your resources. How much can you go with the implementation of that particular quality initiative? How much are you going to factor in terms of budgets, and who is going to lose or benefit in terms of the cost benefit analysis? So at the planning stage also, we use a lot of process mapping or the flow chart or the value stream chains, flows, a lot again in the manufacturing industries, because in the manufacturing industry, things are so linear, but in healthcare industry, things are very, very complex. So every small thing can have its own process, and that process can change very many times in the course of service implementation. Then you have the Pareto analysis or the Pareto principle that looks at, if you have big data, that can also guide the teams in terms of what do they want to focus on as they start looking at the improvement plans or processes. We have the failure modes and defects analysis. Again, I'll speak about this later on. We just go to the next slide. Quality control. We have the SPS, SPCs, commonly known as the SHUAT, control charts, which are very, very important in terms of tracking healthcare process stability. We have the inspections and testing. Again, when you talk about healthcare, sometimes we feel it's just about patient care or service delivery, client level service delivery. But the healthcare industry also has its own industrial or manufacturer sort of components. You have the maintenance departments, we have the machines that we work with, they have to be inspected, they have to be tested for fidelity, they have to be tested for conformity. So all these things are related to what we do in our industry. We have the root cause analysis, and again, many of you must have had this or done this in your settings, looking at the RCA, what is causing the problem, identifying the gaps, the elements that can be sorted at immediacy, at intermediary, and also what can go into further long-term planning in terms of better controls in our systems. We have the check sheets, and the check sheets are usually very, very important, especially when you have very many processes. Just want to identify what is not going right in these particular processes and this particular area of support or care. And then you have the control charts, which I think the species also they come in different forms. Or how is your process controlled? What is your desired limits in terms of performance? Where do you think when things start reaching the upper or the lower limits, you start to put in some maybe other measures or course correction measures? The histograms are usually, you have stable data, things are under control, and we use this a lot where we have stability in processes. So maybe finally on this one is the quality improvement, which is a lot of the focus that has been in the healthcare industry, because this is where we we understand things can change in a significant way in terms of affecting, patient level outcomes, public health outcomes. What do we do? What do we apply? What systems, methodologies do we use in terms of ensuring that things are stable? We have the PDSA or PDCA circles, and I know many facilities have been using this in their own improvement ways, where you are looking at the whole planning. What are you planning to implement or to improve on, and how are you doing it? What are these processes that you put into the system that are going to alter from bad to better or from better to best? And then we have the Six Sigma, not really used a lot in the healthcare industry, but in terms of understanding the fidelity to very, very, very high performance measures, this is where you want to go. You're looking at if there are errors in your system, you want to make them to be less than four errors in a million events, which is extremely difficult in the healthcare industry. We have the lean methodology, where you talk about work area improvements, looking at what are the redundancies in the system. Muma may have come to talk about the 5S or the 6S. How do you ensure that there's lean management, especially when resources are very, very limited in our settings? Very, very important. Kaizen, Kaizen is usually mentioned a lot, but I think it's just a short form for CQI, continuous quality improvement. And this is, again, the benchmark of quality improvement, trying to see things have to continuously, incrementally become better. There's no stopping in terms of patient care, improvement. So everything gets better every other time. New systems, new processes, new equipment, new technologies, pharmaceuticals, and all that. Process mapping, again, also applies in quality improvement. You've seen it again in the planning processes, but also when you are looking at what areas in our process, so in this unit, what is making things, what are the slowdowns, what are the things that are making our processes more difficult for people to follow or to measure or to abide or just to conform. So you draw a process. And when it comes to process mapping, this is where now every player has to step in, and we'll speak about that in another slide. Then the 5 why principles, and I think this has been mentioned in many management discussions and trainings on identifying the root causes in a very quick way. Many times you use the 5 whys with other tools to give you better results. So for the process improvers, or the students or practitioners of QI must have seen this phrase many times, that every system gives you it's perfectly designed to give you the results that you see. Garbage in, garbage out. If you area is designed to give you chaos, then you'll get chaos. If you are designing efficiencies, then you are going to get efficiencies with the system. So it does not occur by accident that you have chaos in a structure, chaos in a system, chaos in a unit. Someone sat down and they designed that chaos, either by omission or commission. So it does not just happen by accident. But what I'm adding down there is that every team needs the right improvement tools to give you the desired results. So, for example, many people know they work in dysfunctional systems. They know they work in inefficient departments or in inefficient units, or they just know whatever we are doing, it does not make sense. But sometimes they just never given the right tools, they're never given the right environment, they're never given the right support to implement what is useful. And if you speak to improvers in other industries, and comparing that to the healthcare sector, is that other industries, they value a lot of the workforce inputs into process improvements. In healthcare sector, a lot of times you find things are designed at boardroom level, because I think it's believed things have been structured somewhere, it has been processed, it has been verified through some Delphi process, so everything is fine. So you go out there and implement. And that's how you realize that in some areas you'll find the same kind of stuff, same structure, but different processes, because people have not involved the care providers in terms of looking at how to effect changes into the system. So we have the Kenya quality model for health, which I always say it's not really a model. It's sort of a platform. It does not prescribe that this is how you are supposed to improve care, but it gives you options. It gives you references. It allows you to structure a team, to bring together a team for an improvement initiative. It provides you the tools that you need to look at what are the core standards of care. I know it's missing in some of the areas like cancer care and other departments, which I think are going to be reviewed and revised. But at the base level, it provides some clear guidelines in terms of what you need to look at structural level. But maybe the things that may not be fully guided in the model is the how, in terms of that down level process of improvement. What are you trying to accomplish? How are you creating an aim? And which tools are you going to use to create an aim? And then if we have an improvement aim, how will you know? What measures are you going to put in place to see that change is happening, And if there are any changes, how will you know that this is what is causing this improvement? So doing that and now putting that into the PDSA circle, and teams are iterating the processes, looking at how things are moving from B to A, very, very important. So I may just maybe want to narrow it down to some of the key essential tools in quality improvement. And please confirm you can still hear me. Okay.
Yes, Peter, we can hear you very clearly.
Okay,
Yes,
okay.
yes, we
Thank
can
you,
hear you
thank
very
you.
well, yeah.
Thank you, yeah. Yeah, so as much as the Kenya quality model for health, we have a training curriculum. I think it has been in existence for some time now. We have, like I mentioned earlier, we have other branches of the healthcare sector that have come up with their own standards, and they've also developed their own curricula. Like I know the Division of RH has the quality of care standards under MNH. Also, we have the quality standards under family planning programs. We have the Kenya HIV sector improvement framework, which is it's an older one, and I think it has been utilized quite a lot in terms of advancing quality improvement approaches, and they speak a lot to most of these tools. So maybe just to focus on some of the tools here, very, very important to know that these tools have to be understood by everyone who is in the process improvement, not to the level of expertise, or not to the level of maybe complete competency, but at least to understand that if I'm having this gap, I'm having this area, I want to look at this particular process improvement, this is where to go. If I'm planning for a new unit, a new ward, what are the things that I need to just to use for me to be guided in terms of making things better in the future. And again, we also have to go with the provider competency. The provider competence assessments are done in different ways in this country. And I think some hospitals have their own competence assessments. Some programs in the country have their own competence assessments. But there's no clear uniformity in terms of what are these assessment guidelines for particular conformance to care, because the healthcare sector is, like I said, very complex. People, different cadres doing different things. One cadre doing a lot of other different processes. Some cadres doing other things that are not supposed to be in their formation. So all this combining makes it difficult to have one uniform sort of a competence assessment. But in terms of a particular process, I think we have enough, maybe not enough, but we have quite some of them out there that have been used before and that are very, very useful. What makes them useful a lot more is when they become faster self-assessment tools before they become inspection or supervision checklists, and that gives the frontline healthcare workers, because usually they are the most targeted group of people when you talk about use of these tools. So I'll speak to some of them here, and one that is becoming common, I think it's very, very common in the countries is the cause and effect diagram. You heard about the Ishikawa diagram, named after the Japanese engineer. And this is very, very essential tool. It has to be part of your improvement folder, because if many times you'll find people are sent to go out there and improve. People attend a training for 5 days somewhere in a hotel. Then on a Friday afternoon, they come up with a work plan, an action plan, and they are told, okay, we'll come 2 months later, 4 weeks from now, we'll see how things are improving. Then when you go back there after those 4 weeks, 8 weeks, 3 months later, things have not moved because they've not applied what tool that is desired to improve that kind of process. So training is important, but if you don't give your program people or your team the right tools, they might not give you the desired results. And I like the fishbone because it's, for me, any healthcare provider can use it if it's well simplified. You don't have to be an expert in it. You don't have to use all the components of the diagram. You just need to identify that out of these components, this is where we are getting the problems, and this is where we want to design our improvement aim. So the team can list different causes under those categories: the manpower, people, methods, environment, machines, or utilities and materials, policy issues. And many times you use the 5Y tool when you are filling in the fishbone diagram. So it's simple, but extremely powerful. Many times you will find people have to go back to the root cause. What are you trying to improve, and what is the root cause? If you're trying to improve something, you don't know the root cause on how it was, maybe the theory around how it might have come to be, then people will just be waiting in the dark corners and wasting people's time in many, many meetings, but really not identifying the root cause. Sometimes people are like, okay, but we know the root cause, we have identified it, but we don't have the tools, we don't have the power to effect it. But let it be there. Let it be there. Let it be known that we identify this as a gap. But because we don't have the resources, we started with a specific element. Maybe if you have like 10 possible root causes for this particular problem, you group them. You say we are starting with these 3 because they're within our limitations, they're within our influence. But you're still knocking on the maybe upper, the upper management to maybe come and fix the other bigger things. So always have that which you think is a big root cause in that folder. And a lot of times, it's from experience, a lot of times, by the time the big things are coming to be fixed, you've done a lot of improvements in your processes. So you don't wait for the big things to come to your aid, but there's always somewhere you want to start with, and this tool will always give you that kind of guidance. The other one is again common in our systems. I know if you're a healthcare provider in any place you work in, you must have seen a flow chart. The malaria treatment protocols, guidelines for ARV management, diabetic care, and then cancer treatment, guidelines and protocols. So these are everywhere. And what makes this very useful is that when you are doing process map as a unit or as a team, you are not looking at the science of providing care, the science of treating, bilharzia, malaria, anything that comes your way. It is how are you doing work? How do you want to make your processes better and better? This is just an example of a flow, and this flow was drawn by a very simple patient walk. Like a client came and we suddenly just walked through with her where she goes from where to which point. And the team realized that there were a lot of redundancies. There are a lot of areas that were very useless to this client and even to the system, but they were so inbuilt into the system that it was very normal. It was very normal for a client working in a unit, stay there for 3 hours, and that is okay, because no one ever looked at what are these areas that can reduce even by half an hour what we do to make everyone's life easier. And this cannot be permanent. Process maps can change, and many times you find a new system, a new management changing a process because they want to identify what are these areas that are making this system not function very well, until you reach a place of efficiency and say, okay, let's maintain this for some time, and then we'll come back to it maybe when we feel like things need to improve. The other very important tool, I know this may not come to the desk of maybe frontline providers, but it's very, very important still at management when they're looking at, what are the primary drivers for this particular improvement aim. We want to improve this care by this much, and we want to do 1, 2, 3, 4, 5. So, but what are these group of drivers that we want to look at as we initiate activities, as we initiate costing of activities, costing of elements, resource mobilization? Where do you want to start from? And what are these things that we must fix? They are very, very primary. If we don't fix them, then touching on the others will not make sense. So this is mostly at management level, at very, very early planning stages. The director, the med sup or the unit head, we want to use a driver diagram to identify what are these key areas that I have these change ideas about what am I trying to achieve? What am I trying to, if I implement these change ideas, what are they going to lead me to? So that gives a more focused perspective when you're looking at your improvement initiatives. The other one that I want to speak a little bit more about is FMEA, the failure mode and effect analysis. This is a tool that it's used to conduct. It's a proactive tool. It looks at how do you identify errors, potential errors in your system. It has not been used a lot in this country, but I know the areas that are trying to implement it, and with a lot of benefits to report. So mostly it was used in other industries to look at what could go wrong if this happens. What could go wrong if we don't fix this particular element? So it requires a little bit of expertise in terms of teams have to be trained on how to use the tool. They have to be given some support on how to implement the tool. So it prompts a team to look at to review what are the failure modes, what could go wrong in this process. We are setting up a new unit, a newborn unit. What are these things that may happen? IPC, what could go wrong with IPC? What could go wrong if we don't have water in the unit? What are the things that can happen if this is not fixed? And it scores you based on the severity of the potential risk. Then it profiles those risks. Then the team can now look at what can we do to fix. I like this tool a lot because you do not wait for errors to happen. You sort of it's like you are in a war zone. So you are attacking before you are attacked. Just walk into a surgical unit. Are they using the checklist? and then do a FMEA. Are they using the checklist as it's supposed to be used, the surgical checklist? Are they using the labor monitoring guide as it's supposed to be used? Then identify what are these elements that can go wrong. And in many cases, people do root cause analysis after an event, maternal death, newborn death, mortality in a unit, fall in the accident emergency unit, client has fallen from the stretcher or something like that. But if we just did a FMEA, you can always see if this is not fixed, we are likely to get this particular problem, and it can be fixed if people are deliberate in terms of looking at those issues. So, this I will really propose and suggest that if for those multifunctions departments or hospitals, you need to look at this tool because it's very, very useful. I've seen it used elsewhere with it gives a lot. It gives a lot in terms of how much you can improve, how much you can avoid errors. Because we always assume that, healthcare providers, they went to college, they went to, medical school, some medical training college, and they came up with a certificate and they know what to do. But we know the human factors in what we do in service delivery. Errors are going to happen. Human errors are going to occur. They occur every day. But this is just to prevent a lot of that from becoming a bigger issue. Okay, histogram, nothing much to say here because I know this is not new to many people, but this is when you're looking at stable situations, things that have been known for some time, stabilized processes, stabilized measures, things that are under control. So you want to see how that's distributed. The histograms can also tell you a lot about a process. If you are improving a particular process and you realize a skewed histogram, it can also inform you, is the data wrong? Are they forcing this process to improve? Because it can be so linear, and it can also tell you maybe there's something wrong. Maybe they're not using the right elements, or they're not working to the right prediction of the improvement over time. I mentioned about the Pareto chart, the principle of the useful many, vital few. Look at your data. What is this that can give you the most profound improvement? You're having medication errors at the pharmacy. What are these errors? What are the things that maybe? Of course, there are many elements, but what do you want to attack first? Look at your data. And this is very, very important if you have a lot of data on you. And it applies in places where, very high client flow or very many processes in a day, like this dispensing units, the radiology lab departments. It can tell you where the problem would be, and we try to fix it using that tool. But again, many of these, like the Pareto chart, requires a lot of manual preparations. I know there are tools out there automated, but in many cases, just a simple Excel, you insert your data and it gives you what you want to look at and what you focus on. But it doesn't mean that when you're attacking the vital few elements in your system or in your production, you forget about the others. But the others are also very, very important. And you also have to come back to them at some point and fix them. Or many times you are fixing the other bigger areas, few, but with the larger impact or effect, then the other also will just benefit from that. Okay. I think 5S, 6S, this has been around for some time. Work area improvement. This has been applied for many years in this country, in many hospitals. But when I look at 5S or 6S, of course the sixth S is the safety element, which is very, very important. Of course, patient safety quite critical. But when I look at the 6S, I always think it's not just a tool. It has to be a philosophy. It is a mentality. It's not just about going into a department and decluttering and removing, things from the store and rearranging them. I think it's just about the mentality at the workspace. What are these things that you need to sort out straight from your own preparation as a manager, provider, office worker? What are these things that you put in place to make things easy for you? And what are the redundancies? What are the elements that you want to look at that can make your workflow better? I think when it was first used in the industries, it was like, they used to call it, I think, the Gemba walk Kaizen. People walk and just try to see what are these things that are not useful in this department. They arrange them. You have this bed that is faulty, that it's just even affecting people when they are doing the ward round in the ward, in the department. And why is it there? I just remove it. You have these processes, handoff processes, that are not useful. Just eliminate them from the system and make that to be a practice. That's why you find some places you go, the floor is just better than another department which is next door. And it's because they will just remove they've sorted the areas, they've standardized, cleanliness is part of the team mentality. It's not a show off. It's part of the system, so that when you walk in a department, you realize, this place people don't litter. This place people don't just leave files open, patient files open. They are well arranged somewhere. In this place, the stethoscope, the beeping machine is kept somewhere, So it becomes a mentality. It's not like you wake up one morning and say, okay, I'm the manager, let's rearrange this department. No, it has to be infused into a system. And that is how the 5S works best. Because if it's a matter of just people going to a hotel and they're trained on 5S and they go back, never works. So it's a management function. You have to infuse the work area improvement mentality into the team for it to be more effective. I'm feeling like I've talked a lot. I'm almost finishing. So the other tool that is very important in improvement, SAC, of course, the measurement. You have to measure what you are trying to improve. We've had about the run charts, or the line charts that look at how is a process being controlled, not really controlled, how is the stability of the process, what are the areas that are showing appropriate improvement, what are these key signals that you look at. We talk about run charts a lot of times in the improvement processes because they give a lot in terms of what you can get from that system, what you can observe from what you're trying to achieve or what you're trying to improve. So control charts at the same time, there are many types of course, many of them out there, but you want to go to that area if you really understand how the run chart gives you that kind of stability. So at the control chart level, they'll be used for different areas, different elements, and appropriateness. Maybe you can just focus a little bit on the run charts. They have their own rules to identify, to determine if, things are just happening randomly or things are changing because of what you're putting into the system. Are you seeing a shift in the process over time? Of course, using the median as the unit of measuring the stability here. Are you seeing a trend? You sometimes you see people presenting in a meeting and they've seen one data element in a quarter performance and they're like, we've really improved. Then when you go back again 6 months later, things really never improved. It's just like a random thing, something happened. So you have to measure over time to deduce that whatever you're trying to put into the process or into the system is really giving you the desired results. So teams have to be shown how to interpret the run charts. It's not a function of the M&D people or the data people. It's a function of improvers to understand how to interpret the run chart. And this is very, very important. And like we say in improvement circles, if you are doing any improvement without a run chart, then I don't think you are doing any improvement work. It's a lot of wasting people's energy and time. The scatter diagram, again, not used a lot in most situations beyond and academia research and looking at differentials in some attributes. But again, it's also useful. It can also identify what are these correlations in the improvement that we are trying to look at? What are the things that these two variables, what are the positive and negative attributions to each other, and how can we relate that to what we are trying to improve? So for me, those are the most, not for me, but I think universally, those are the most useful improvement tools that we can apply across the sector at different levels. The others are inherent in different structures, management in the planning processes. So those are always being used. But if you want to see effective improvement and leading your frontline staff or frontline healthcare providers and the whole healthcare service sector, you want to focus on and build your team's strengths and capacity on those tools. This is the last one, which is mostly I bumped into this lately. So it looks at you have a team that is trying to improve a process, but how do you measure the team's maturity? You score them. What point do they do what? Are they maturing in terms of their capacity to apply the improvement science into the processes? Are they what is your prediction? So this Curtis of IHI, it's used in many of their programs, but something that we can also apply in our healthcare settings in the country. So I think I have to go back to you, Anne, but big thank you to everyone. And of course, the Society, the Medical Association, Kenya Medical Association, RUFA, and the Kenya Association of Private Hospitals. Asanteni sana.
Well done. Thank you so much, Peter, for unpacking that so very well for us this afternoon. To the participants, thank you so very much. And I'm sure you've learned something on quality improvement and quality initiative. Various tools we can use to improve our patient care, and of course, improve our standards and ultimately quality and patient safety. I now invite your questions. I see someone asking for slides. I think this will be uploaded in the website by the Kenyatta National Hospital, and that can be accessed. So any questions from the participants? Questions from participants? I also would like to acknowledge the other members of our Society for Quality Healthcare Kenya, Health Kenya. We have our president, Dr. Lydia Uktoi, who is also present, and we have had our secretary, Dr. Rhoda, who has been present, and I can also see other members like Dr. Mike. Thank you so much all for joining. So any questions? No questions from participants? Peter, it seems that you are very, very clear. Okay, so someone is asking a question here, Peter.
Yes.
And they're saying, how do you learn the RCA tool and use it effectively? Every time you use it, the team does not agree to the root cause. Any idea on how to gain these skills?
Thank you. Thank you very much for the question. So I think the beauty of people differing when they are looking at the root causes is that many times it's just how are you facilitating the process. And one of the things that we use a lot in our settings, but we don't apply it so well, and we know it, we do it every time, is the brainstorming. The brainstorming is a very powerful tool. But brainstorming, sometimes it is used to to test theories, which is not the right way to use it. The brainstorming session when you're doing the root cause analysis, just to bring out everything to the table like, we used to call it somewhere, you're throwing the spaghetti on the wall. Whichever sticks can stick. Whichever does not stick, that's fine. At least it hit the wall. So you allow everyone to ruminate, to provide what they feel, what they think is the root cause. Then the point where, because in quality improvement, things always converge and diverge. So when you're doing the brainstorming and we're doing the root cause analysis, ideas are really divergent. They're going all over, outrageous. People are just saying stuff. But if you are managing that facilitation well, if you're moderating that session well, you identify all these ideas are just as important at that moment. Then when now things start to converge is when now you start scoring in terms of affinity. Scoring, there are other tools that you can use, the like priority matrix. For this particular root cause, what is the impact at scale? How is it affecting this process to a score of 0 to 3? Everything is usually a little bit subjective, but it gives you some level of conforming that we can start with this set of root causes and identify their change ideas or the countermeasures to them, then move forward. So for me, it's all about how do you moderate that session. People are never going to agree every time, but when it comes to scoring what is useful, people cannot score a 5 if it's a 1 many times. So that's when now objectivity comes in. But anyone else can answer this? Dr. Lydia, Mike, anyone in the room, please.
Thank you so much, Peter. And just to chime in on what you have said, when you are doing a root cause analysis, it's always, if an institution has the policies, protocol, pathways, and standards, or some guidelines, for example, if you are looking into a clinical process, you can look at that process. What was the point of deviation? So that there is no push and pull. You're just looking at what went wrong. Basically, in a root cause analysis, we are not looking at who did what, but we're just looking at the process and trying to see where are the gaps and how can we mitigate this from happening next time, or what do we need to reinforce or improve so that we do not have a recurrence of the same. I don't know whether anyone from our team has something to add about root cause analysis. I see now questions are flowing in. Peter, there are more questions from you. From participants for you. There's someone asking about which MOH facilities are applying the principles shared. What have outcomes been? I think I can answer this and say that in our next session, which is a monthly session, we do these quality sessions on a quarterly basis. We will be bringing some health facilities who have been sharing this, and they will be demonstrating to us what they've been doing on the ground and what are the outcomes. And they will share with us also what have they learned from implementing the KQM. And also, Peter, there's another question here. PDSA cycle can fail. What happens after that?
Yeah, thank you. And thank you for that question, and thank you again for that note on there are many public facilities that are doing this, even private. I think we'll host one next month. They can tell us their story. But it comes to PDSA failing, and that's the beauty, because they fail and you learn something from that circle. The PDSA usually there has to be small circles of change. You don't do those big PDSAs because those are now transformational projects, big time, big things. You already realize this has to change. It's like you're building a road. You already identified things that are going to be affected by that road. So it's a major thing. So that has to go on because it's not going to fail. When it talks about PDSAs are useful when they are picked in small portions. You start this process, you plan, you do, you measure, then when you're trying to measure, you realize, this is not making sense. This is not going to the right direction. Let's go back to the drawing board. Many times, maybe you didn't pick the right root cause. You identified something that is just easy, common to everyone. Everyone can just do them with their eyes closed. Then realize your process is not even improving, despite all these efforts. So again, you have to be ambitious in identifying what are you planning to achieve, what are you doing, and how are you measuring the processes? Because a lot of times, and from the experience, is process measures are very difficult for teams. People measure outputs. People measure client delivered, client given injection, but people do not measure the process of just how was that injection provided, how was the setup for this client for labor and delivery done, how is the flow of this patient from the NHIF to the doctor's room, to the cancer treatment room. How was that process structured? So people don't measure those. People just want to measure how many patients we saw at the end of the day. But if you put process measures into your PDSA, then the failures are very, very important because they inform you next time, please omit this, next time include this. Yeah, so failure is not bad improvement. It's also a lesson, and it's a very good lesson. Thank you. Back to you, Anne.
Thank you so much, Peter, for that. There's also another question here. They're asking, who should be the quality champion in a facility?
Can someone help me here? Mike, Lydia, Rhoda, please. Who is a quality champion? So I'll try. Because we are so much at the level of starting things in QI. I used to think that some of these high level systems have done a lot in quality improvement, and things are just flowing until I went to a high level facility, and they were just doing the things that we are doing in a health center in the rural Kenya. So it just never stops. But the thing is that you do not identify quality to a person. And that's why the movement for us, society, is to ensure everyone is on the table. Because if you create a room, a specific unit, a specific department, like an audit office for quality, then things start getting isolated. It becomes an office function. You have to bring it. I'm struggling to bring the words out, but you have to bring it out to the surface so that it does not become a championing thing. It becomes a way of life. It becomes part of what we need to be doing as soon as we step out of medical school and become part of our behavior and culture. So it does not become like it's a special course, it's a special skill, it's a special training. Of course, you have to be trained, you have to have the competencies around it. But let's demystify these quality departments. They are very useful at the initial stages because you are setting a system in place, you are setting a unit in place at county, sub-county, department structure, but let it permeate beyond the office walls so that it doesn't become like Peter or John is a champion of quality in this department. No. And that's where you find when that champion leaves, things just now start collapsing because it was all invested in one or two people. Yeah. Back to you, Anne.
Thank you so much. You've answered it so well that our quality is everyone's business in a healthcare institution. Another question here. How do you ensure that our quality initiative standards are being enforced in different facilities in the country? I guess this one we can leave it for next time so that when we share with how well the QMO has been implemented, we will be sharing some of these examples. But there's a question here for you, Peter. On the Pareto chart, can we include blood and blood products? That is, wrong blood group if possible.
Thank you so much for the question. So Pareto chart becomes useful when you have a host of many, let's say, errors or gaps in the system. So if the blood works is a problem, so there are many other things that may have happened for that to be so. Is it the labeling? Is it identifying the donor? What are these things that add up to that? And then when now you're using the Pareto chart, many times you must be having quite a little bit of data for it to be more useful. So and again in critical essential clinical services, clinical elements, you don't again wait for big data. Sometimes some big errors that have happened, then you just have to attack that error in its own isolation, like just in time sort of processes. We don't have to set up this complicated committee and everything, because many times we want to implement a whole improvement initiative based on one isolated incident. If there were floods, sorry to use that analogy, if Thika Road is flooded today after just flash, heavy downpour, I don't think the cabinet is going to sit tomorrow morning to identify that is a problem to fix. But if we see Thika Road is every morning for the next 3 months, just gridlock, people are not moving, then something has to act to work. It means it's not an isolation. It means something is inherent into the system. So now that's where now QI comes in. You are attacking a process that is underperforming, not an incident that I don't like using this example, but like the MPDSI, maternal death audits are done and everything. But if you're doing your FMEA in that maternity unit and identifying the errors, you are going to do much more than what you would have done by identifying what is this that has caused this mama to die. So there are things that may have told you this is likely to happen if you don't fix this. This is likely to happen if you don't fix this. So I don't know if I'm answering the question, but yeah, those are my perspectives. Back to you, Anne.
Thank you very much. And as we wind up, there's a question here, and I'll add one more. In a setup where you are the only technical staff, how do you come up with an efficient work improvement team? Offering quality in such a setup is hard enough already. What are your comments, Peter, where this person is the only technical staff and they really want to implement an efficient work environment?
Yeah, and I guess this applies to many of us in this country. You are in a unit, you're in a rural settings, a dispensary, you are the only person who opens and closes that door, and you're expected to improve processes. So it is still possible to improve, very possible. Many times, maybe there's someone that you work with. It could be a cleaner, it could be the guard, it could be someone, a casual staff who works with you. There are things that you can just improve. And if you are measuring what you're improving, or if you're measuring what you're identifying as a gap, then it is easier to fix it because you know what you're trying to improve and you're measuring it. For example, you'll hear many people say, we have a workload issue, we are understaffed and everything, but how do we measure you're understaffed? Can you just create a chart on your wall and say, on day one, on this day, I saw 20 patients. On this day, I saw 25 patients. On this day, I saw 50 patients. Draw that as a line graph. And anytime someone walks to your department and say, okay, guys, this is my workload. This is on the wall. This is how it looks like here. I'm just giving a very wild example. And because you are measuring what you feel is a process that needs to change, then it becomes more, I can't say more easier, but it becomes more focused. In fact, you can also, if anyone came to your aid, can easily have a discussion with you and identify how can we fix it. And we've gone places where just by that analogy, by just that comparison, you identify someone to come and relieve you, or someone to back you up, or to support you in one way or another. Yeah, even a one-man department can improve in a nutshell.
Yeah, thank you so much. Peter, you've also asked the second question that I wanted to ask. Now that you did show and you've demonstrated several tools that can be used. So just wanted you to say or to tell the participants how does a facility start implementing the tools, and you have just given us an example. You could start with a histogram, a line graph, and from there we pick it and one will know where to improve from. So the last question here is talking about can QI be applied in a rehabilitative service unity? And how can environment be addressed in root cause analysis, especially in facilities situated in hostile environment? Probably you can answer those two as we wind up here.
Sorry, I don't know if I'll answer all of them. Maybe I can attempt the rehabilitative services units.
Yeah.
Maybe just to answer this is that QI functions in the 4 areas of healthcare. You know, healthcare exists in four things. One is to prevent ailments. The second is to ensure those who become sick, of course, they get care. And the third one is to ensure those who may not get better with medical attention or surgical attention, they get better rehabilitation or they cope with their ailments in future. And QI also applies in the other element of healthcare, which is coping with terminal situations, you know. So the quality improvement applies in all those spectrums. So in rehabilitation, again, it's important because there are many areas that you can improve, and the tools are there. You just need to identify your gaps. You just need to identify your gaps, and you get some training. It's not really complicated. Get some training, some orientation on some of these tools, and you are ready to go. Many people struggle with where to start. And again, that's where now management has to come in. So the management has to build that group of how do I start my improvement? Where do I start from? Which tool do I use? How am I going to collect data? Then from there on, everyone in every department is always willing to improve. Yeah.
Thank you very much, Peter. This very last question, I think I'll help Peter. Say, how can environment be addressed in a root cause analysis, especially in facilities situated in hostile environment? I guess when the participant is asking about hostile environment, could be maybe the work environment, which is not very, very friendly. But I think for us to gain more in our quality improvement initiatives is to have all stakeholders' involvement. Let it not be a top-down model, but could we start from the grassroots by a simple session as brainstorming? With this in your facility, ask from the cleaner, from the guard at the gate, what do you think can be improved in this facility? As you go up and let everyone's voice count as you try to implement, even if you are picking a root cause analysis, go into the real issue and separate it from people. Because sometimes why implementing a root cause analysis can be difficult is when we go already pointing fingers at people and saying, you did that, who was there? It's not about who, it's about what happened. So I don't know whether I have really answered your question, but I think having everyone on board and looking at issues from a process perspective rather than an individual, that would help you implement or address a root cause analysis in your environment. With that, we do wish to thank you very much for your very active participation, and thank you very much. Just a reminder that we do have these sessions on quality every first Wednesday of the month. The Society of Quality Health of Kenya, where we have sessions on quality matters. So you can always join us. You can drop us an email to the society, and we'll be happy maybe to respond to your questions or to come to where you are and assist you to work and implement something on quality in your institutions. Remember, we say that our mandate as a society is to ensure that quality is implemented in each and every community, in each and every healthcare facility in the country, in in the best way possible, regardless of the resources. And I see the team from Kenyatta National Hospital is reminding us of the upcoming seminar on Saturday. Please register and plan to attend this session. Once again, thank you very much. And also an apology that we did not have the second presentation from the Ministry of Health due to technical hitches. Our sincere apologies. We will try our very best to have these tools of implementing Kenya quality model for health standards unpacked for us and see how well we can integrate them in our various health facilities. Once again, thank you very much for your time and for your active participation. Thank you.
Thank you all. Bye.
Thank you.